Dr. Guha, please.
It's always.
He is the Director, Sai Retina Foundation, and an international figure.
So can I have the So thanks Shubhendu, Aniruddha, Devdulal, my heartthrobs from my city of birth. Nice to see Deepender here, and nice to be always, because I grew up here. Two institutions I owe my education: National Medical College and Don Bosco School, Park Circus. So without much ado, the first case, there are three cases assortment. First case presented after resurgeries in a case of a massive macular hole, maybe 3000 microns in diameter, with subretinal PVR, which we had to manage. And the second case, the duration lengthened long because of the incessant bleeding that occurred due to, you would see a Eales case, presumably Eales case. Eales is never a definitive diagnosis, so presumably Eales case with a mid-peripheral neovascularization, which we had great difficulty in tackling and stopping the bleeding. It's very easy to tackle diabetic bleeds, on the contrary. But Eales, sometimes proliferation, because preoperatively you're not giving anti-VEGFs, so those bleedings are very difficult to control. And the way I isolated and then treated that area would be shown. And the third, last but not the least, case of a very old chronic traumatic macular hole in a case of a young girl, and for which we did a autologous retina transplant with very good results. So first case, that multiple surgeries, maybe 6 of them in a separate center, presented to us. And after dealing with the preretinal membranes, which took a lesser time, we had to pull on the, already 360 retinotomy was done in the previous case. So we just pulled on the retina and marked out with diathermy those areas, and unfurled the retina and yeah. So we started dealing. This is a typical tug of war maneuver, which using a forceps and spatula in this case, which is extrapolated from the epiretinal tug of war fashioned by Dr. Cyrus Shroff long back. So this is the same tug of war method used subretinally. So this area was carved out for the autologous retina transplantation to cover the massive, very huge macular hole, almost 3000 micron in diameter, and placed. We put oil, of course. And this was one of the very early cases of ART that I attempted. Of course, we now have a big series of cases in various indications: myopic macular hole, detachments, traumatic macular, huge chronic macular holes, macular holes in BRVO, macular holes in diabetics. So, so peripheral retina does have good neuroretinal degenerative potentials, and thank you so much. And was placed, and we got good results in this case. PFCL silicone exchange being done at the last part. This is the case of the peripheral fibrovascular neovascularization in the case of presumably Lees disease. And after clearing the central vitreous, the location of the fibrovascular patch was such that it was incessantly and made it a long surgery. It's coming down. So we are vacuum cleaning repeatedly up to the and then we decided to, while we were tackling the vitreous base, we decided to, I'm using depression and so that the area is highlighted. Sorry about the colors. So we isolated, because the main concept is to isolate that vitreous base, because we can't dissect. Because the banyan tree type thing is not those vascular epicenter type things you see in a diabetic. So very difficult to dissect. So you cryo that area also, add cryo. And in the second stage, I actually, not shown here, I did a retinectomy in that area. And here's the last case, ART in a huge traumatic macular hole. This is a pre-op picture. and after the usual PVD induction. There was a dialysis also in this case, peripheral, which we lasered effectively. We didn't have to buckle the dialysis. After ILM peeling, we choose a area superiorly, relatively avascular area, and harvest ART graft out of that. Here is by using a 41 gauge cannula, this is my technique. And initial cases, so I did a lot of diathermy. So much of diathermy is not necessary. Just you do a 4 marker diathermy and you fashion the roughly 1.5 times the size of the hole because of the latest possibility of shrinkage of the graft. And you would see the end result was very good. We did have, I collaborated with Rohan in RP Center for the microperimetry and some uvulous spots at the edges of the hole you would see when I show the microperimetry, and vision improved from hand movements to 624 now, and almost more than 2 years follow up. And the earlier cases, unnecessary, I put a drop of Helon just to, not necessary. And here I put gas, SF6 gas. So the initial days, the graft making took a long time. It was a post-op fundus photo, post-op early OCTs, and late edematous changes take place, as Hani Hamza also showed us, and Tamir have shown us. And these edema settles down over, it takes a long time to, you'll see, 332 days after. The edema is lessening down. This is the microperimetry, and some yellow spots are there at the edges. And thank you so much.
Dr. Guha, would you prefer to do the cautery around the graft before from the donor area?
As Rupak also showed in his series of cases, I already mentioned that I did too much cautery. But at the end, you would see synaptic, ectopic synaptogenesis also taking place in that graft, in spite of the cautery, as he also showed in his series of cases. But definitely just a 4-point cautery nowadays.
But in the retina and the mid-peripheral area, vascularity is not that less. So if you take the graft from the periphery, the vascularity less, so you can, no need to do the cautery. But if you are doing it from the mid-periphery, you have to do some kind of cautery, but you can do it after taking the graft.
Mechanical advantage, you
yes.
can't go too much to the periphery. So it's easier to, after that you'll have problem placing the graft.
Yes.
There is the lesser distance the graft has to travel, the lesser chance of the upside down of turning of the graft.
So are you using PFCL during this procedure?
Yes, yes.
Okay, thank you.
Thank you. Thank you so much.
Thank you, Dr. Guha, for joining with